Bismillahirrahmanirrahim. Wassalatu wassalamu ala rahmatil alameen. Assalamu alaikum. I trust that you're in best of health and spirits. Today we're going to talk about the adrenal gland and relevant diseases. Before we jump into the pathophysiology, just a quick overview about the adrenal gland. Adrenal gland is a triangular or a crescent-shaped gland located above the kidneys bilaterally. It is divided into two portions, the medulla, the inner part, and the cortex, the outer part. The cortex is further divided into three zones. The first, glomerulosa, the G stands for glomerulosa. The second one, fasciculata, and the third is reticularis, the R, reticularis. So glomerulosa usually produces aldosterone, a mineralocorticoid, under the action of angiotensin 2 and weakly under the action of ACTH. So ACTH, adrenocorticotropic hormone, which is secreted by the anterior pituitary gland, acts on these two zones and it produces, the F fasciculata usually produces cortisol, which is a glucocorticoid. So aldosterone was a mineralocorticoid and cortisol is a glucocorticoid, gluco. And reticularis usually produces the androgens, the steroids or sex hormones. So this was about the location, structure, and the function. Now, as the name indicates, mineralocorticoids is usually responsible for the regulation of electrolytes, particularly sodium and potassium. So if you have less sodium in your bloodstream, in your body, so aldosterone would want to reabsorb more and more sodium from the kidneys, aldosterone. And it would want potassium to be secreted by the kidneys into the urine and then out of the body, it's excreted. So glucocorticoid, on the other hand, as the name indicates, it is usually has a number of functions, but primarily it serves as a stress hormone. It wants the body to have a sufficient amount of glucose inside the blood to be utilized under stress conditions, under fight conditions. So this is important as terms of function. And the other function of cortisol is also in the cardiovascular system, in the muscular system, to regulate the blood pressure. And a very important function is you can say to somewhat decrease the immune function, the cortisol. So these are some of the important functions, and rest you can go study more into the physiology. And if you have any relevant questions or if you want a separate lecture, you can just write in the comment section. So we have discussed about mineralocorticoid, aldosterone, glucocorticoid, cortisol. Now the important diseases, of course, it's a very important gland and relevant clinically as well as the license examination. So the important diseases relevant to the adrenal gland is Cushing Syndrome and a Cushing disease, and Cone Syndrome, hyperaldosteronism, and adrenal insufficiency. So these are the diseases which you should know if you are going to attempt any medical license examination. So first of all, some of the most important disease is Cushing Syndrome. So what is Cushing Syndrome? Cushing Syndrome is increased level of cortisol inside the blood, hypercortisolism. So what can be the presentation? How can you suspect? So now you would see a clinical case on your screen, and I hope you would be able to answer it at the end of this lecture. So you can just pause the video and read the case, and at the end you should be able to answer it, inshallah. So coming to the Cushing Syndrome, the presentation. When can you suspect a patient suffering from the Cushing Syndrome? So I have just drafted a mnemonic. You may have your own. So C, Cushing. C can stand for central obesity, and also a buffalo hump at the back. So a patient can present with such clinical presentation, but if not the buffalo hemp, but at least the central obesity, the abdomen. The second is U. Okay, so the weight goes up. So that's why I said arrow up. The weight goes up. So the weight is increased, but there is proximal myopathy. The extremities, they are thin. The limbs, the lower limbs and as well the upper limbs. So they are thin, proximal myopathy. Why does this happen? Because cortisol function is to break down the proteins, and our muscles are made up of proteins. So if they degrade the proteins, our muscles would be thin, and fat is stored inside the abdomen. So there is central obesity, while the proximal myopathy, the extremities are thin, they are weak. S stands for striae. So striae is a purple discoloration of the skin due to breakdown of collagen, you can say, and it's usually visualized inside the abdomen. H is hypertension and hyperpigmentation. So hypertension, the patient can present with hypertension, and if a patient is presenting with central obesity and hypertension, or central obesity with hyperpigmentation, or hyperpigmentation with hypertension, so you should think of Cushing. So hyperpigmentation is usually under the action of ACTH. If ACTH is more, it wants melanocytes to be produced more, and it causes the sun exposed areas to be more dark. So that's called hyperpigmentation. Then IN stands for infection. A patient who is likely suffering from Cushing would have a history of recurrent infections. Why? As we discussed previously, that the cortisol inhibits the immune response somewhat. And the last but not the least is glucose intolerance. So Cushing patients usually suffer from impaired glucose metabolism, and they can suffer from diabetes. So this is now secondary to hypercortisolism, unlike type 1 and type 2 diabetes. Okay, so this was Cushing syndrome, the presentation. So if a patient is presenting with any of these systems, not all of them, is 1 or 2 or 3, so you can suspect Cushing syndrome. And once it is suspected, what would be your next step? Your next step would be to screen the patients. To screen. So screening. So how can you screen the patient? The patient can be screened with 3 type of tests. So there can be 11 p.m. salivary cortisol levels. There can be overnight dexamethasone suppression test. It's also called DST. Low dose, this is low dose DST. And the third one is 24-hour urinary cortisol, UFC. Okay, so you can screen with any of these. Of course, the most convenient would be this one, 11 p.m. or the overnight, not the 24-hour. It's just not, of course, the patient might be admitted in the hospital, but this can be no need to admit the patient. It can be in an outpatient setting. So once you have screening, and if you get abnormal values of cortisol levels, in the overnight low dose, you give a low dose of dexamethasone at night around 8 p.m. and the next day around 8 you check the cortisol levels. And so once screening is done, you need to confirm it. There should be confirmation of the abnormal value. So how can you do it? So simple, you need 2 different screening tests to confirm the diagnosis of Cushing. So for example, if you did 11 p.m. salivary cortisol and you get abnormal values of cortisol, so you can do an overnight dexamethasone test or 24 UFC test. And if you get abnormal values of cortisol, so then Cushing is confirmed, hypercortisolism is confirmed. Now you need to know what is the cause of the excess of cortisol inside the blood. So it can be due to pituitary adenoma, anterior pituitary adenoma, and it's the 60 to 70% of cases. The cause is the pituitary adenoma. The second, it can be ectopic, or there can be adrenal adenoma, or there can be ectopic production of ACTH, ectopic production. other than pituitary gland ACTH being produced inside the body. So once confirmation is done, and I've told you how to confirm it, then there would be ACTH assessment. ACTH assessment. So ACTH assessment, you check ACTH levels inside the blood. It can be decreased or it can be normal to increased. So if it is decreased, the next step can be just to CT MRI of abdomen to scan the adrenal glands. But if it is normal to increase, there can be two causes. Either there is a pituitary adenoma or there can be ectopic ACTH secretion. So to confirm the pituitary, what do? You do a high dose dexamethasone test and MRI to screen the pituitary gland. So high dose dexamethasone test is usually the same as low dose, but it's 8 mg dexamethasone. And in this case, if it is positive, if the MRI is positive and the test decreases the level of cortisol and or ACTH, so then its pituitary is confirmed. And if it is not decreasing the ACTH or cortisol levels and the MRI is not showing any pituitary lesion, so you can suspect ectopic ACTH secretion, and you can either do IPSS. So if the pituitary MRI and the HDDT is inconclusive, so we can go for IPSS, which means inferior petrosal venous sinus sampling. So if this sampling bilaterally is also inconclusive, so then ectopic is most likely, and we should do the CT MRI of the chest and abdomen to find the ectopic cause of ACTH secretion. And if this is positive, so we are confirmed with Cushing disease. So Cushing disease means the pituitary adenoma is causing the Cushing syndrome. So what is the treatment? The treatment is usually a surgical intervention, of course, but you may need medical intervention if the patient is not suitable for surgery, or there is a bridging therapy until the surgery can be done. So you have different drugs, just like to inhibit the steroid synthesis, just like ketoconazole, which is a first-line drug, or there can be drugs that can block the cortisol receptor, just like mifepristone, and there are also certain drugs which inhibit the ACTH secretion. So this was with the Cushing syndrome and Cushing disease. The most important part is the screening and confirmation. So you should know this part particularly. Thank you for watching.